to this webinar by HaystackAnalytics, the title of which is The Vital Role of Genetic Screening in Pediatric Healthcare, Early Detection and Improved Outcomes. My name is Dr. Aparna Bhanushali, and I'm the moderator for this session. At Haystack, I'm the director for medical genetics. We take care of this vertical. I would like to share that Haystack, we are a health tech company based out of IIT Mumbai with a mission to bring genomics to the forefront of healthcare. So our first flagship product was on TB, whole genome sequencing, which was recognized as one of the top innovations by BIRAT. It was also showcased to our Honorable Prime Minister during the BIRAT day, where from several startups. This is ours was shortlisted or picked to present to the Honorable Prime Minister. So our the TB product overcomes what is the provides the drug resistance profile across all the 18 antibiotics that are used in the management of TB, and this is a major step towards realization of our goal to eliminate TB from India by the WHO goal was by 2030, and we hope to hit. In addition to that, we also have a product which is on infection, called as infection, which identifies pan-bacterial, pan-fungal, and antimicrobial resistance in several sample types, and that helps in in antimicrobial stewardship. So for all innovations, we have been supported by several of the premier academic institutes of our country, like the BIRAD, the DSC, Science, and so on. We have also been, we also partnered with several of the diagnostic providers as well as hospitals, which have uptaken our solutions. So our journey has been very interesting. We established in 2019, where we got the Startup Award company, where we got a Maharashtra Startup Award, and the company was incorporated. In 2020, we developed a TB whole genome sequencing test. In 2021, we launched the TB genomics test across India. We also received the BIRAT Big Grant for TB in 2022. In 2023, we've launched the TB pan-genomics, the TB genomics test across pan-genomics across India, as well as provided support to the BMC for COVID sequencing. In 2024, we got the City Digital Transformation Innovative Award of the Year, and we also received the Tech Startup Award. In 2025, we have this our lab, which is at Tulse, has received the NABL accreditation, and several of our tests are under the scope of NABL. We also offer sequencing services to several academic institutions as well as diagnostic providers across different domains, which will include metagenomics, human genetics, and so on. So that is about Haystack Analytics. I would like to introduce our guest speaker for today, Dr. Praveen Gokhale. Dr. Gokhale is an esteemed pediatrician and well-renowned. He is the president of the Thane Academy of Pediatrics. He is also the executive board member of the MMR Mumbai Maharashtra 2025, the vice president of the Maharashtra State of Indian Academy of Pediatrics, the finance chairperson of Mahapedicon 2023. He's the director of critical care, MRR Children's Hospital Thane, and also a consultant with Jupiter Hospital Thane, Bethany Hospital Thane, the Kausalya Medical Foundation Hospital, and the Hiranandani Hospital Thane. He has been an investigator for several of the vaccine trials of phase 3 and pre-marketing survey trials, and has been a reviewer for various journals and research papers which have been published in peer-reviewed journals. So with that, I would like Dr. Praveen Gokhale to take over. But before that, would just indicate a few housekeeping rules. We would really appreciate if all your queries can be typed across in the Q&A section or the chat box. We will be addressing those queries at the end of the session. So without much further ado, Dr. Praveen Gokhale, over to you.
Thank you, Dr. Aparna, and I hope I am audible to everybody so that we don't have any further interruption in the presentation.
Sir, you are loud and clear.
Thanks a lot. So I think we can ask the technical team to start with the presentation for today and today's topic.
Sure.
So as we are discussing today, as Dr. Aparna has introduced, that we are going more and more towards evidence-based medicine. And nothing more can be more evidence-based than the genes, because the genes don't lie, because they are the ones which are responsible for most of the human functions. They're responsible for most of the hormones, enzymes, and the various processes that are happening inside the body. And most of them are responsible in some way or the other in the kind of diseases that we encounter. Either it will be a direct consequence or it will manifest in some kind of a phenotype of a non-communicable illness. So of all, what we are interested in the genetic makeup is a rare disease, because like we all are general pediatricians, basically we all are finally dealing daily with OPD patients. We many of the times are encountered with a case that stumps us completely, like what we think, and the tendency is that we rather advise some kind of investigations which were available to us before, and we knew that the yield from those results, the lab tests, was very low. Okay, then we had some kind of a test which came as the metabolic test. So it widened our scope of diagnosis. And now finally what we are doing is that in our student days, we used to always have a chapter, at the end of the chapter, a small note on genetics. Like you take any illness, at the end there will be a small note saying that these are the genes involved with such type of a condition, which we always used to overlook because we never did those tests at those point of time, and we knew it was not going to be an exam question. But coming the full turn now, we have now to get ourselves acquainted with those last paragraphs and lines of those type of illnesses, because these are the tests that are now coming to the forefront, and now we are in a position where if we are clever enough to use them properly in the proper situation, we will be able to achieve much more than what we were doing before. So 350 million people worldwide have rare diseases, and to compare that, it is greater than the entire population of USA. So the burden spread worldwide is almost equivalent to that of one developed country. There are 7,000 plus rare diseases, and most of them are due to genetic mutation. The rest 20% may not have a direct genetic basis, but in some way or the other may be a consequent to the underlying genetic material. 25% of the global patients with rare diseases lie in India. So India contributes to 1/4 of the rare disease burden. And recently we had two conferences in Mumbai itself, in KEM Hospital and Wadia Hospital, which were the first rare disease conferences. And why these rare disease conferences came up? Because there is such a lack of knowledge regarding tackling of these conditions. The knowledge that availability of tests is there, knowledge that the treatments are available for many of these conditions which were previously thought to be untreatable. And so it came, and then the last question is that of a gentle care, like a care to be given where a genetic condition cannot be cured completely. But how can palliative care be given to such patients to achieve some standard of living for them as well as the parents, because the family as a whole gets affected whenever there is a rare disease. And then there is always a question, is that if there is one rare disease diagnosed, what does it what does it hold for the family in future? Okay, is it a spontaneous mutation? Is it a inherited condition? Or how is its transmission? And what is the possibility that the parents may have it in the next pregnancy? So 70% of genetic disorders usually start in childhood, but 30%, that is a significant number, start in adulthood. Uh, Although the early life of the child and as adolescent may be normal. Next slide. So current scenario for newborn screening. So newborn screening is a concept. Basically, we know that the newborn screening may actually start with the congenital anomaly scan done by ultrasound. Then we also know that there is some kind of screening that is available in the form of the prenatal testing to see whether the fetus is harboring any harmful genes. Then we have got screening for hearing, screening for vision, screening for metabolic disorders. So Hilprick test is a metabolic disorder screening program where a mass spectroscopy is applied to enable simultaneous detection of multiple metabolic disorders. Here it is mentioned 7 disorders, but there are almost 100 disorders that can be diagnosed by tandem mass spectroscopy. Then there are biochemical tests which require substantiation by enzyme assays, especially the storage disorders. Mass spectroscopy based tests for metabolic disorders, as I've already told. Uh, Tandem mass spectroscopy is nothing but two or three spectroscopes arranged in a linear fashion so that the number of metabolites picked up by them increases. And the immunoassays for hormonal disorders, phenotypic based tests such as hearing test, 2D echocardiography, which now almost like I'm to say it's becoming like a screening test in some centers, and the molecular test for hypothesis-based diagnosis of clinical conditions, and that is the genetic testing. Now, why we are moving very rapidly towards newborn screening? Like even a 2D echocardiography, when I started practice, there was only the first machine came to JJ Hospital when I was a student, and the first machine in Thane came when I started practicing in private practice. And that time it was just the doctor used to diagnose, and then the child used to be referred. But nowadays, in certain situations, we have reached a type of care where, like I'm going to say, we have to preempt any type of complication, like screening of 2D echocardiography screening. The proponents say that if you screen on the day one itself, there are certain congenital heart conditions which manifest later on. So those can be picked up and detected. So we don't know what is correct and what is wrong right now. But we are slowly moving towards a situation where parents don't want any nasty surprises. And one of the screening programs that we have for detecting hidden disorders is one for the metabolic screening. That is the inborn error of metabolism and other type of storage and lysosomal disorders. So parents don't want any nasty surprises because nowadays the child norm is 1 or 2 children per family. And the cost of morbidity of having even a single rare disease in the family is astronomical. Apart from the emotional destruction the family suffers. Okay, it is the cost burden that in a society like us or in a country like us where there is no government support for such type of morbid conditions. I hope in future it is going to slowly happen because there have been instances where recently certain rare diseases got a sanction from the government that it will be treated free of cost. And I hope it gives a lot of succor and emotional balm to the parents of affected children. But we are still far away. And considering that our country's burden of rare disorders is enormous, we can put a large amount of economic resources just to treat these conditions or do palliative care. Rather than that, I think if we are moving towards a prevention type of a strategy, it will be better in terms of the morbidity load the country will carry as well as the economic savings it will have for the country. Next slide. So drawbacks of the present screening tests are they are focused tests like screening test for the autoacoustic emission, which is again not a final test. Sometimes the children can fail it. They have to be referred again for the test again. Then it has to be again sometimes if it is doubtful, we have to do ABR to see that everything is okay. And in spite of that, there are certain kids where there is still a doubt remaining. So no screening test is perfect. but we are trying to reach as close to a perfection in every type of test that we perform as a screening. And then there are tests based on clinical phenotypes presented by the infant. Like your infant may have coarse clinical features suggestive of congenital hypothyroidism, or maybe there will be after a few weeks, or in the first year itself, the child will manifest with coarse features suggestive of MPS, and so on. And so, how the child's appearance is can give us a clue of what is to be screened for him. Then there can be multiple tests to identify inborn errors of metabolism. Overlapping syndromes can sometimes lead to diagnostic odysseys, because sometimes there will be children with seizure disorders where we are not able to come to a conclusion just by only seeing the child or treating the child. Here we have to go to the depth and find out whether there is child also harbors some kind of a neurological condition which is manifesting as seizures, but we are not able to diagnose it at the present moment. And then there are difficult to diagnose rare genetic disorders where none of the above all screening tests combined together can provide a perfect answer, and that this is where the challenge lies. But 90% to 95%, we can come to some kind of a conclusion based on all the tests about the phenotype and what type of a direction of treatment the child requires, and some kind of advice for parents for further pregnancies. Next slide. So why a comprehensive diagnostic test is crucial for genetic disorders is that almost 4% of newborns are affected by genetic condition. The increasing incidence of newborns with genetic abnormality is known because, see, there are various aspects of birth right now, apart from normal conception. Now, what we have seen in the last decade is that the age of the first pregnancy has itself gone up. Now, sometimes in where we are attending deliveries, it is rare to find a mother below age of 30 years delivering her first child. Okay, because of professional challenges and the aspirations of everyone. Okay, the concept of parenthood has gone from the second decade to the third decade, and with increasing age there is an increasing risk of genetic abnormalities because the genes are always the undergoing some kind of a transformation in the egg cells also. Okay, so the it's not that sperms and ova is just silent. Okay, they are sensing all the environment surrounding them, and they are undergoing certain type of changes in their genes, and this is passed on to the next generation. So this is what is the environmental or the learning memory of the genes, that for the first 30 years, whatever the mother and father have undergone, the emotional impacts, the environmental impacts, the food impact, the metabolic impact, all of this is being sensed by the germ cells, and it is getting passed on to the next generation. And that is why the incidence of genetic disorders increases with increasing maternal and paternal age, the classic example being of the trisomies. So this is the easiest example to understand. And there is a high mortality rate in newborns due to genetic disorders. Now, there was a time even 10 years back where every sick child in the NICU used to be thought of having an infection. But now with better care, we have come to know that not all of them are infections. Many of them are metabolic disorders. Many of them are genetic disorders. Many of them are disorders of respiratory center, and many other type of disorders. Some may be motor neuron type of disorders that is the spinomuscular atrophies, etc. So what initially was thought of only to be a domain of infections, the NICU has now become a domain where there will be infections, but there will be sick newborns due to various other causes that we are diagnosing nowadays, and that is where the genetic and the metabolic disorders predominate. 825 diseases are resulting from variants in the 800 genes. So more than 2 different diseases are caused by 25 genes. So that is why the number of diseases is slightly more than the number of genes, because there is a difference in the expression of phenotype even when there is a single gene involved. It all depends on where is the breakage, and depending on that, the severity of the disorder can be determined, or the quality of the disorder, or the phenotype change that undergoes may be different in 2 different individuals, where the same gene may be implicated, but the type of disease or the severity of the disease may be different in 2 different individuals having the same genetic disorder. Next slide. So what is the solution? The solution in genetics came across with the identification of the entire human genome and finding out which type of genes codify for which type of hormones or which type of enzymes or are responsible for causing which type of congenital defects like heart defects, or sometimes there will be defects of collagen. For example, will be Marfan syndrome, etc. So what it gave us was that the next generation sequencing gave us a potential to analyze a large number of genes simultaneously to identify disease causing ones. Now we are not going to map out the entire human genome in every single person that we are going to test for diseases. However, we are going to apply certain templates to his genetic material where the templates are capable of getting attached to abnormal genes and highlighting them and telling us, yes, this is where the defect originates and this is where the problem lies. So the next generation sequencing helps us to identify all the variations and mutations associated with genetic disease. Like for example, we know that sickle cell anemia and thalassemia may have multiple, they have got a different type of a mechanism and they have got multiple mutations associated with a single disorder depending on where the genetic, what is the genetic makeup and for how long the chains of hemoglobin are produced, the alpha and beta genes. So the next generation sequencing will identify all the variations and mutations that will cause an abnormal hemoglobin chain, okay, or the smaller hemoglobin chains. And we will be able to know most of the mutations and the illness will be same, but the mutations and associated with these will be identified very clearly. So it is able to identify more disease conditions with a single test. Now we need not have multiple testing to be done on a child to identify a genetic underlying genetic condition. Many times from outside, we just don't know what is this condition. Then we start thinking, should I do a urine sugar? Should I send this enzyme in the blood? Or should I send this type of a very specific type of a genetic screen to diagnose cystic fibrosis? Or should I send us a certain type of fluorescent in situ hybridization to detect some kind of anomaly? Okay, so now the thing is that whenever we diagnose a phenotype, there may be many genes associated with certain type of disease conditions. So sometimes sending such type of specific type of test may defeat the purpose because your test may come out negative, yet the problem will remain unsolved. So here the problem can be tackled by doing the next generation sequencing, which will sequence out all the genetic material and will not miss any type of a condition which mimics the condition you are thinking is the cause of the disease. Next. So next generation sequencing technology is nothing but analyzing our DNA. It is done by the next generation sequencing. It employs the entire exome is analyzed in this. Okay. So if there is a condition beyond the conditions which are being screened, okay, and being reported to you, even that time the test has a capability that your geneticist will be able to call you up and tell you that apart from the screening, we have detected something else also, which is a little bit rare because the screen for genetic screening used is mostly for conditions which have got some kind of a implication in terms of treatment, implication in terms of prenatal diagnosis, or implication in terms of prognostication. Like there are some 30% adult disorders which are present in adulthood. So if you get an advance warning that this is the genetic type of this individual who is more prone for developing some kind of adult disorder, it will help us in understanding how that particular individual needs to be monitored. So it is like an advanced warning system. The whole exome sequence screens all the exonic and coding regions, thereby expanding the scope of testing to a wider spectrum of disease or conditions. And it is a cost-effective and comes with a good TAT. Now, there is a difference between a newborn genetic screen and a whole exome sequencing. In the way that even the newborn screening genetic test will employ the whole exome sequencing, but we are not focused that we have identified some material, like some kind of a illness. Okay, we are doing it for prognostication or where there's some kind of implications that we are having. But in whole exome sequencing, when you are sending that, we are not able to really, type the person or the illness to a particular type of a phenotype. Like you may get an individual where there is a pancytopenia, and you want to know which kind of leukemia this is. So you have already given the geneticist the background of the child's condition, and the geneticist will apply certain type of screens to understand what type of leukemia it is, or aplastic anemia. But there are certain type of a mixed type of genetic disorders where, from the external features, they have not yet completely manifested themselves. Or there may be certain pointers, but you don't have any evidence in hand to say that this might turn out to be this. And that is where the whole exome, because you want to nothing to be left undiagnosed in terms of genetic type of identification. While the purpose of newborn screening is to identify the treatable and conditions which have got treatment implications and implications for the adult life. So when you apply a screen, it comes as a little bit cost effective, and it comes with a good turnaround time if the volumes are high. So even now, if you see that whole exome, when we send to any particular lab, the turnaround time is a good 1 month, because they will load all the samples maybe on a weekly basis. And there will be some labs who get a heavy load. They may be loading it twice a month, so that your turnaround time may be a little bit less. But as the volumes go up, the turnaround times are definitely going to come down to less than 2 weeks. Next slide. So impacts of implementing genome sequencing in newborns. So the whole exome sequence of 159 newborns was studied, out of which 127 were healthy newborns and 32 were in newborns in neonatal intensive care units. And this is a very small sample, but it is just an example. So the childhood onset of disease risk was 9.4%. Actionable adult onset disease risk in the newborns that were tested on was 3.5%. And carrier status or recessive gene status for various type of diseases was 88%. So all of us carry some kind of a recessive gene in us. And that is why what happens is that it may be rare. Every one of us may be harboring some type of a recessive status. But for two same recessive status to come together and reproduce an offspring, to have homozygous state becomes a little bit rare. So most of us are still enjoying a healthy life only as a carrier status. But that doesn't mean that we are not carrying the genes. The carrier status is there, and it is as high as 88%. And the pharmacogenomic variants will be around 5%. So the detection of disease risk in newborns with clinically healthy phenotype is somewhere what is classified as a childhood onset disease will be close to 9%. So combination of healthy newborns and sick newborns put together, you get a risk factor of around 10%, where you will find somebody's sample size. I think I will not really be too worried about, because it's a very small sample size. When you screen out in thousands, you will really know the entire story. Next slide. So impact of implementing the genomic sequencing. So take example of United Kingdom, where 9 children are born each day in the United Kingdom with a rare and treatable genetic disease, where early intervention is crucial. So even in the developed country like United Kingdom, 9 children are born each day, which may require some kind of an intervention. Compare this to around 67,385 babies born in India every day. The cohort size is humongous. And you can just imagine the amount of newborns that will be born with rare disorders. So we don't really know. So on the left side is not the cohort, the UK cohort is not mentioned. What is mentioned is that they know that there are 9 children who are born each day in UK with genetic condition. On the other side is mentioned the human cohort of India per day. That is around 67,000 babies delivered per day. If you extrapolate that, around 10% of them may be harboring genetically. So around 6,000 babies per day are born in India, which may have some kind of a genetic problem. And that number is quite humongous, with a 50-fold increase in birth rate compared to UK. So now you understand that we have got a 50-fold increase birth rate compared to UK. So if we multiply, the possibility of higher rates of newborn disorders is significant in India. Okay, so if you multiply, say maybe 9 by 50, okay, so you will get to say approximate figure where, like I'm to say the amount of newborns who will be having a genetic disorder in them. So let's leave out the numbers. The possibility that we are having a high pool of genetic problems, we all know that it is there, and we are working towards what can be done about it. Next slide. So next generation disease requires next generation diagnosis, which is provided by new generation sequencing, which is using the new generation sequencing, which is called as DGX. DGX is one of the offerings in this spectrum. Next slide. Most comprehensive one-time single test that screens for all known actionable hereditary disease. Now, all illnesses are not in newborn screen. As I told you, we have selected the illnesses which are known for their implications in terms of treatment, management, and implications for adult onset diseases. Okay, now all adult onset diseases have a spectrum. Some start in adolescence, some start in adulthood, and some start in old age. And there are some illnesses which have got a spectrum starting from childhood to adulthood. Depending on what phenotype they are going to express, it will start manifesting that time. So it covers almost 209 type of conditions. Next slide. So DGX pediatric comprehensive test is a screening test. A genetic screening test is performed to inherit for diagnosis of inherited genetic disorders, which identifies the genetic, metabolic, hormonal, and functional disorders based on the gene sequencing, not on the based on other tests. You can always, like for example, if you diagnose a galactosemia in a genetic test, which is rare because first the child will manifest as illness. You will diagnose it by certain type of inborn error of metabolism screens, and then you will be interested in knowing the genetics also. Okay, so but there are other disorders which will identify the gene first, especially those which have got a later manifestation. Like you are doing a genetic screen at maybe 6 months of life, and the disorder usually starts manifesting by 4 years of age. Then you have the advantage that you have identified it by genetic test before any type of abnormal metabolite, enzyme, or hormone goes out of sync. So it facilitates a timely intervention to prevent severe health complication and death. And therein lies it the importance of NGS is that where, how, and when to apply to this to certain patients is the skill that you will have to develop in conjunction with ethics and dilemmas, so that you don't go either overboard or neither do you remain in the dark, okay, not diagnosing any particular condition. Now, who should get tested? So it is especially meant for sick premature babies where you are not reaching any particular conclusion, or even healthy premature babies, because it is nature's law that sometimes prematurity is the outcome of basically nature pushing out a baby before birth because it doesn't want it to survive. Okay, so premature babies, you can apply the DGX screen to know that is there any underlying reason for a premature birth. Babies with low birth weight, again, the reasoning is the same. And there are babies or children with family history of genetic disorders. Like the parents have given you an idea that there has been a fetal loss or two children previous to this bad obstetric history, two full terms, they have got delivered and they died within a month's time without identifying a known cause, and many such type of clinical situations. Here, definitely you should advise that a genetic screen is in place. In fact, the parents should have been screened before the pregnancy to understand, like if they had a fetal loss or a full-term loss or a premature loss, okay, with certain type of features in the baby, they should have undergone the genetic screen themselves to identify whether they carry any identifiable risky genes in them before proceeding with the next pregnancy. And it can be applied very easily for children 0 to 18 years old. Like there have been cases where there have been siblings and the first sibling passes away with some kind of a blood disorder. Okay, and the parents are very anxious what will happen to the second child. It's the same thing happens in hepatic disorders also. So the elderly sibling has some kind of PIFIC or hepatic condition leading to cirrhosis. and the elderly sibling dies, and they are more keen to know what will happen to the younger sibling. And in this situation, genetic test will help, because if there is some gene mapped out in the elder child before mortality happened, you will be able to screen out this child also to know whether the child has the same type of gene in him or some kind of variant associated with it. And we can give the parents the idea to prepare for this child for further treatment. Like maybe the elder child did not receive the benefit of a liver transplant because it was too late to do it. But the younger child, they can both start, pulling the money economically and being mentally prepared. Okay, that in case such a eventuality happens, then they will be prepared for it. Now, the same gene in both the children will not cause hepatic failure with precision. The first child may have had a hepatic failure and succumb to the illness, but there will be always instances because the phenotype of the second child may be different. He may be harboring the gene, but it may not be expressing itself in this child to an extent where he will undergo some kind of a liver ailment very early in life. He may just carry on to adulthood or maybe even into the beyond 60 years, and it may start manifesting at that point of time. So it is all diagnosis of a genetic or of a particular gene in a child does not mean that you can give a prognostication in all cases that this is what is the outcome going to happen in a few number of years. That cannot be done because the expressions are different. Next. So again, here the age of onset and age category and the number of diseases are shown. So most of the neonatal screening that happened is for detecting the illnesses that happen in childhood. Okay, so if you can see the age from where the number of diseases manifest, okay, it is usually in the younger age that you get the highest number of illnesses that can present themselves. But as you move forward, okay, the age at which the disorders can manifest can vary. So it can come in adolescence or late adulthood or early adulthood, depending on the gene or under genotypic expression, leading to some particular type of phenotype which may manifest a little bit late. Okay, but to understand that he carries the genetic material is important in certain type of clinical situations. So you can see there are 22 neonatal conditions, there are 24 neonatal infancy conditions, and as you move downwards, infancy, childhood to adulthood, 10 conditions manifest. Adolescence, adulthood, congenital with in infancy and congenital in childhood. And there are certain disorders which can manifest at any age. Okay, next slide. So pediatric comprehensive testing for newborn screening, there should be strong evidence stating genetic variants causes the said condition, and it has to be matched to the phenotype properly. High proportion of individuals with genetic variants are expected to have symptoms causing a debilitating effect on quality of life if left untreated. Early or pre-symptomatic intervention of the said condition shows substantially improved outcomes. Especially we know that there are certain lysosomal storage disorders nowadays which have got enzyme replacement therapy, which can improve their survival and even the quality of life to a great extent. And there are certain conditions where the bone marrow transplant is a solution which can give a good quality of life in subsequent years. And conditions screened for are only those which interventions are equitably accessible for all. So these are the 4 parameters on which the newborn genetic screen is based on. Next slide. Pediatric comprehensive report to report for the gene variants detected, pathogenicity of the variant, and conditions or disorders diagnosed. So first is the genetic variant which is detected in some form of a number, which you see in the first column. Then the pathogenicity of the variant, whether it is a heterozygous condition, homozygous conditions, and whether it will result in a pathogenicity. So when a particular gene variant is detected, it has already been mapped out that this is likely pathogenic. And so the report will tell you that it is likely pathogenic. While it is graded on a scale of 7. Okay. So probable or most probable, less likely, and all those type of variants from 1 to 7. And more likely pathogenic And last is the pathogenic, that this type of a variant detected is 100% pathogenic because it has been typed out from the phenotype to the gene, and it has been shown that whenever this is detected, it has shown pathogenicity. So that comes into the second column along with the genetic inheritance. And lastly, they will report that we have detected the gene, but what does it cause? Like it causes Ehlers-Danlos syndrome, whether it is a detection of Marfan, whether it is detection of some kind of a gene for aplastic anemia or some kind of a lysosomal storage disorder. So that illness will be reported in the last column, because you don't know by looking at the number in the first column what this gene stands for unless you are really heavily into genetics. So the report confirms the presence of an inherited disorder and aids in the decision of the need for any assistive technology. So genetic screen is not the last answer, but there are certain type of microarrays and other type of sequencings which are further available, for which the geneticist will be the best person to tell about what further can be done in certain special situations. So it aids in future decisions and to enable prescription of appropriate medicines for the current case, and to give advice to the parents for future pregnancies. Informs on the need of increased surveillance for worsening of the disease. Like if the disease is going to have a manifestation in adolescence or adulthood, it will be good to uh, counsel the parents that if it is the first sibling, okay, they should go in for a prenatal diagnosis before implantation of the next pregnancy, so that they know that, like I would say, they don't take risk of sequentially having two children which are going to manifest as an adult or adolescent onset illness in later life, and then come to know later on, oh, like I would say, this was all genetic all along, and the early childhood was spent almost normally. So these are very cruel situations in life, and we have to learn that we have technology in our hand and how to apply it to larger benefit of the society. Next slide. So here it is actionable based genomic MBBS. Can see the condition, metabolic disorders, blood disorders, hearing loss in the first column, and the example of conditions it causes, like propionic acidemia, carnitine palmitoyl transferase deficiency, then PK, phenylketonuria, congenital hypothyroidism, and so on and so forth in every column. Like for blood disorders, you have the spherocytosis. For hearing loss, you can connection related hearing loss, Pendred syndrome, congenital heart defects associated with Marfan or any other type of heart defects associated with trisomies, immunodeficiency disorders, pediatric cancers like hemangioblastoma, neurofibromatosis, tuberous sclerosis, xeroderma, epilepsy, seizures, fires, vision loss, oculocutaneous albinism, optic atrophy, etc., and other type of disorders are the examples of conditions which are getting screened out. And there are certain treatment options for metabolic disorders, for blood disorders like surveillance transfusion, for hearing problems, you got the hearing aids, devices, cochlear implants. For surgery, for heart conditions, you have got corrective surgeries or palliative cardiac surgeries, or planning for surgery, because Marfan manifestations of cardiac illnesses, like aortic dilatation, can result in later half of the life. Like when you cross 50, it starts manifesting. It starts manifesting from adolescence in some Marfans, and in some it starts manifesting very late. So again, you have got a full spectrum of age or spread over decades. Okay, so that is where it will help you in increasing the surveillance and planning for your future health. Prophylactic administration of antibiotics, bone marrow transplantation in immunodeficiency disorders will be a corrective type of a treatment for immunodeficient disorders. For pediatric cancer, increased surveillance and screening, routine, and of course, bone marrow transplant. Then for epilepsy, routine monitoring, anti-epileptic and other type of neurological disorders. Again, it will help in the genetic planning for the next pregnancy, and so on and so forth. Next slide. So there are certain type of scenarios which are now present in this slide. I may go a little bit fast. Only one case I will give you, then I leave the floor open for the questions. So the confirming diagnosis of Dravet syndrome. Dravet syndrome is nothing but a severe epilepsy syndrome, typically caused by the pathogenic variants in the SCN1A gene. So scenario is that the child presenting with recurrent prolonged febrile seizures in first year of life. Clinical suspicion of Dravet syndrome was based on seizure description and developmental history. Intervention was targeted genetic testing. Here the phenotype was there, that is the epilepsy phenotype. Okay, so it was tested against the epilepsy, chronic epilepsy phenotype with whole exome sequencing. And there was a confirmation of the SCN1A mutation, which provided a definitive diagnosis of Dravet syndrome. And what it did was it helped avoid unnecessary tests. Okay, so we knew that this is epilepsy phenotype and we need to treat it accordingly. Next slide, one more case, and then I stop. So confirming diagnosis in family counseling for assessing the genetic risk. So scenario is that the parents with a child diagnosed with Dravet syndrome want to understand the recurrence risk for future pregnancies. So inheritance pattern of Dravet syndrome is autosomal dominant. De novo mutation was found out in the SCN1A with a low recurrence risk. Like the parents wanted to know whether one of them is carrying a SCN1A gene. Okay, both of them came normal. So this was a spontaneous mutation. And spontaneous, whenever there is a spontaneous mutation, the risk for next pregnancy is equivalent to the risk for general population. That is the 1 to 2%. Okay, for any illness, it carries for any there is 1% risk that we will have the second child will also have a spontaneous mutation even if the parents. So it's a low risk. So they can go in for the next pregnancy with a 1% risk. So recommended test for families with a known mutation, prenatal testing or pre-implantation genetic testing. Now they want to make 100% sure that the next child does not have this type of a SCN1A gene. So they can go in for the pre-implantation genetic analysis of the embryo. And when they find out that this is not at the 8 cell stage, it is not carrying the genetic SCN gene of SCN1A, they know that the risk for this child to have epilepsy remains at par with the general population, that is 1%, and provides clarity on the reproductive risk and family planning options. So these parents now, when they have understood with the prenatal pre-implantation genetic test that this child, this embryo does not carry the SCN1A gene, they are going ahead with the pregnancy with a caveat that nobody can assure them that the second child will not have epilepsy. The epilepsy risk will be same like the general population, except that it will not be a Dravet syndrome. Next slide. So on and so forth for pattern disease and various, we can discuss in some other presentation, some other day. Next slide. Long QT syndromes are extremely important cardiac syndromes where you want to understand whether there is any known genetic condition underlying it. Okay, especially pathogenic variants are known, that is the KCNQ1 or KCNH2. So there is a treatment guideline for this type of condition by implantation of the cardioverter defibrillators and beta blockers. And you know that it is being carried in the family with a varying type of penetrance. Next slide. So benefits of the newborn screening: identify genetic biomarkers, identify rare disease with a single test, enables the appropriate patient care at the earliest and prevents complications and mortality. So identify earlier, intervene earlier, access the treatment earlier. Next slide. So these are all the type of genes which are listed out for just to inform you that it is an extensive table across which the genes are being tested out, and it is a very specific type of a test. There are no generally pathology errors or lab errors. Next slide. Only caveat is that when you take the sample, you need not have a blood transfusion given before that. That is the only caveat. For any type of genetic testing, if you have given a blood transfusion, which is very common in the NICU setups, then there is other method by which you can use the buccal mucosa swab. The cells from the buccal mucosa are analyzed in this type of situation. So you have to understand if you identify something which requires genetic testing early, especially in a preterm baby where you know blood transfusion may be required due to anemia of infancy, take the sample before the transfusion is given and send it for genetic testing. Rather than getting compromised later on when the babies become too sick later on and then you want to do a genetic test, you are going to lose the baby. You want to do a genetic test, but you already given a blood transfusion. So it will not be a very specific test. So there you can use the child's buccal mucosa for testing out. Next slide. Thank you all for a very patient hearing. And I give the floor open to Dr. Aparna.